Finals SAQ 91 Back Pain. A 68-year-old woman attends the pain management clinic with a 2-year history of pain in her back and legs. A. Describe the pharmacological and other treatment options with examples available for this lady. Pharmacological options includes paracetamol, but not to be used alone, NSAIDs, assess risk and benefit, consider need for gastric protection, use lowest dose for shortest duration possible, weak opioid for acute management if NSAID not tolerated, contraindicated, or ineffective. Weak opioids should not be used long-term and it's not for sciatica. According to NICE Guidelines 2020, do not offer the following for low back pain or sciatica: SSRIs, SNRIs, tricyclic antidepressants, gabapentinoids, antiepileptics, oral steroids, and benzodiazepines. Other treatment options includes self-management, which includes reassurance, education and counseling, information, and advice to continue usual activities and exercise. Exercise including group NHS classes, such as biomechanical, aerobic, mind-body, or a combination of approaches. Manual therapy only as part of an overall management package. These may include spinal manipulation, mobilization, or soft tissue techniques such as massage. Psychological therapy such as cognitive behavioral therapy to be used within a pain management program. Pain management program is all interventions combined into one package of care, i.e., combined physical and psychological program, which may include education, exercise, relaxation, goal setting, pacing, psychological therapy, return to work program, etc. Invasive treatments includes epidurals. Consider epidural injection of local anesthetic and steroid in patients with acute and severe sciatica. Do not use epidural injections for neurogenic claudication in people who have central spinal canal stenosis. Radiofrequency denervation of lumbar medial branch for patients with positive response to a diagnostic medial branch block. Other injection options includes trigger point injection, facet joint interventions, sacroiliac joint interventions, hip joint injection, and piriformis muscle injection. Spinal cord stimulation is an option for radicular pain. Consider spinal decompression for patients with sciatica when non-surgical treatment has not improved pain or function, and their radiological findings are consistent with sciatic symptoms. NICE Guidance 2020 does not support the following for treatment of low back pain: transcutaneous electrical nerve stimulation, TENS, acupuncture, percutaneous electrical nerve stimulation, PENS, orthotics, manual traction, ultrasound, interferential therapy, spinal injections, spinal fusion, and disc replacement. B. What factors would alert you to the need for further investigation or referral? This includes the red flag symptoms or signs. The mnemonic is tuna fish, T for trauma, U for unexpected weight loss, N for neurological symptoms. For example, motor or sensory loss, progressive neurological deficits, cauda equina syndrome with saddle anesthesia, gait disturbances, urinary retention and overflow, and fecal incontinence. A for age, more than 50 or less than 20. F for fever. I for IV drug abuse. S for steroid use. H for history of cancer, HIV, immunosuppression, constant progressive pain, no relief with rest or night pain, systematically unwell with unintentional weight loss, night sweats, severe fatigue, osteoporosis, deformity, non-mechanical pain, and marked restricted movement. Red flag signs and symptoms identify whether there is risk for serious disease. Yellow flags indicate psychological risk factors for developing chronicity. This includes negative attitude that back pain is harmful and potentially severely disabling, fear avoidance beliefs and behavior, high baseline pain and disability, sleep problems, tendency to depression, low morale and social withdrawal, pain catastrophizing, expectation that passive rather than active treatment will be beneficial, general health related such as opioid use and sedentary lifestyle, irritability, toxic relationships, perceived reduced control of one's life, work dissatisfaction, social or financial problems. Differential diagnosis for back pain. This includes musculoskeletal 95%, nerve root or radicular pain 4%, and serious spinal pathology 1%. Source of musculoskeletal pain includes sacroiliac joint, facet joint, discogenic pain, ligamental injury, myofascial pain, etc. Features includes dull mechanical backache. Referred pain to legs is common but not below knee. Those aged 20 to 55 years old are most affected. Nerve root or radicular pain is due to disc herniation, spinal stenosis, or epidural adhesions. Features includes well-localized sharp electric shock pain, typically radiating below the knee, exacerbated by coughing, straining, or sneezing. Straight leg raise or femoral stretch test will reveal nerve root irritation, and neurological examination may show sensory, motor, and reflex abnormalities. Serious spinal pathology. Examples include cancer, cauda equina syndrome, fracture, and infection. Their associated red flags are illustrated in this table. Other ways to classify the differential diagnosis for back pain includes that from ATOTW 2023. Causes of specific mechanical pain includes disc degeneration, facet arthropathy, myofascial pain, sacroiliac joint arthropathy, spondyloarthropathies, vertebral body fractures, microfractures, and end plate degeneration. Causes for neuropathic pain includes herniated disc, spinal stenosis, neoplasms, and malignant spinal lesions. Causes of infection includes herpes, pyogenic spondylodiscitis, and vertebral disc osteomyelitis. Low back pain may be complicated with nociplastic component. Back pain may be referred pain from visceral organs such as abdominal aortic aneurysm, gastrointestinal, renal, and pelvic pain. The differential diagnosis for back pain can also be classified as intrinsic spine, systemic cause, and referred pain. Intrinsic spine pathology includes compression fracture, herniated disc, lumbar strain or sprain, spinal stenosis, spondylolisthesis, spondylosis. Systemic causes includes connective tissue disease, inflammatory spondyloarthropathies, malignancy, vertebral discitis, or osteomyelitis. Referred pain may be from abdominal aortic aneurysm, gastrointestinal such as pancreatitis, peptic ulcer disease or cholecystitis, herpes zoster. Pelvic conditions includes endometriosis, pelvic inflammatory disease or prostatitis. Retroperitoneal conditions such as renal colic and pyelonephritis may cause referred pain to the back. Additional information for low back pain. Low back pain is pain in the lumbosacral region extending distal from the costal margin to above the inferior gluteal folds with or without leg pain. It can be caused by specific pathology such as infection, tumor, ankylosing spondylitis, or fracture. However, the cause may not be elucidated. It consists of several types of pain, which includes nociceptive, neuropathic, nociplastic, and non-specific. Low back pain may be triaged into three types: non-specific low back pain, not attributable to recognizable or known specific pathology; specific mechanical low back pain, which is localized to the low back without radiation to the extremities; and radicular pain, whereby pain extends into the knee and usually below the knee. It also can be classified as acute, less than 6 weeks, subacute, 6 to 12 weeks, and chronic, more than 12 weeks. Chronification is the process of conversion of acute to chronic pain. There may be loss of mobility, decreased function, abnormal perception, mood and cognition, and pain-related behavior, changes in social interaction, and occupational difficulties. Risk factors for low back pain includes genetic factors, female sex, sedentary lifestyle, obesity, smoking, psychosocial factors, poor coping mechanisms, occupational hazards, secondary gain, and greater disease burden. Causes for low back pain, as previously mentioned. Evaluation of low back pain. From the history, identify pain generators to plan treatment. Determine the presence of mechanical pain. Exclude red flags and yellow flags. The PQRST mnemonic is useful to take a history for back pain, which includes provoking or relieving factors, Q for quality of the pain, R for region and radiation, S for severity, and T for timing. Examination includes inspection of posture, gait, and the back for scars, alignment and contour, range of motion, including flexion, extension, rotation, and lateral bending, palpation of the spinous process, paraspinal muscles, greater trochanter, posterior superior iliac spine, and gluteal area, neurologic examination of power, sensation, reflexes, and digital rectal examination. Regarding the dermatome and myotome for the following spinal segments, L3 and L4, motor includes knee extension, hip adduction, sensory, anterior lateral thigh for L3, medial ankle foot for L4, deep tendon reflex, patella. For L5, this includes hip abduction and great toe extension. Sensory is dorsum of the foot. For S1, motor includes great toe flexion, toe walking and plantar flexion, and hip extension. Sensory, plantar surface of the foot. Deep tendon reflex, Achilles tendon reflex. Provocative tests include straight leg raising test, slump test, femoral stretch test, cam or facet loading test, and sacroiliac joint provocative tests such as SIJ distraction test, thigh thrust, Genslen test, SIJ compression test, and Faber test. Other pain generators can be assessed including hip and tender spot survey. Regarding investigations, in most patients with low back pain, imaging modalities are unnecessary. Imaging can usually be delayed for more than 1 month unless there is a red flag. Imaging modalities support clinical findings by giving visualization of vertebral alignment, mobility, disc disease, facet disease, or fractures. Options include pain film X-ray, which is used primarily to image bone anatomy, 2D or 3D CT scan. It is superior for imaging bone anatomy, metastasis to the spine, and rapid assessment of trauma. MRI is best for evaluation of neuro and soft tissue. Regarding NICE Guideline 2020 for assessment of low back pain and sciatica, think about alternative diagnosis when examining or reviewing patients with low back pain, particularly if they develop new or changed symptoms. Exclude specific causes of low back pain such as cancer, infection, trauma, or inflammatory disease such as spondyloarthritis. If serious underlying pathology is suspected, refer to the relevant NICE guidelines on metastatic spinal cord compression in adults, spinal injury, spondyloarthritis in over 16 years old, and suspected cancer. Consider using risk stratification tools such as the Start Back Risk Assessment tool at first point of contact with a healthcare professional for each new episode of low back pain with or without sciatica to inform shared decision-making about stratified management. The Q Start Back screening tool is included here for completion. Based on risk stratification, consider simpler and less intensive support for people with low back pain with or without sciatica, likely to improve quickly and have good outcome, and more complex and intensive support for people with low back pain with or without sciatica at higher risk of a poor outcome. Regarding imaging, do not routinely offer imaging in a non-specialist setting for people with low back pain with or without sciatica. Explain to people with low back pain that if they are being referred for specialist opinion, they may not need imaging. Consider imaging in specialist settings of care, such as a musculoskeletal interface clinic or hospital, for people with low back pain only if the result is likely to change the management. These are my references. Thank you.